Well, we'll come back certainly on that during our discussion at the end of this session. But first, we will learn and let's say, inspire from some good examples abroad. But first of all, also, we will learn a bit more on the activities of the European Diabetes Forum, which will be introduced by Professor Chantal Mathieu, who is indeed Professor of Medicine at the Catholic University of Leuven, where she's chair of the endocrinology in the hospital of a department at the University Hospital Gasthuisberg in Leuven. And then she's also, of course, amongst others, vice president of EASD and president of the European Diabetes Forum, but also, as you may guess, a very active member of the Belgian Diabetes Forum. I give the floor to Professor Mathieu.
Thank you, Philippe. And if I can have my first slide, or you give me the control? Okay, I can do it. Okay.
Yeah.
So indeed, European Diabetes Forum, that is how actually everything started in Europe, with the idea of European Association for the Study of Diabetes, the ESD, who said, if we want to really weigh on policy in Europe, we need to have everybody. We not only need the researchers, not only need the clinicians, we need people living with diabetes, we need the nurses, we need industry, we need everybody to be on board and speak with a harmony of voices to really make a difference. And why diabetes? Well, this is one of my favorite pictures taken from IDF and WHO, actually. When you look at Europe and you put the number of people living with diabetes in Europe in the year 2030, it means that diabetes land is the third biggest country in Europe. And that means something. It is a very, very prevalent disease, and I don't have to convince this audience that it is a disease that affects the lives of people. There is mortality, but as Laurent said, there's also a lot of morbidity. And when looking at cardiovascular disease, renal disease, etc., and also a disease like cancer, diabetes is very often the very fertile soil where these diseases grow. And I don't even mention COVID. Also, when looking at diabetes from a policy perspective, it is obvious that it is an expensive disease because of all of these morbidities. And so, we believe that if we want to change something in Europe on the domain of diabetes, we need, first of all, data to, as you can see, measure outcomes, define outcomes, but especially also improve outcomes. Also, we believe we need integrated care. Our country is a very good example how integrated care can make a difference in a disease like diabetes. Laurent, again, already alluded to the trajet de soins. We also have the involvement of primary care, very important in a disease like diabetes. And then finally, also access to novel technologies, virtual tools, etc. And so what European Diabetes Forum did was bring together stakeholders to really align the voices. And here I show you who is partners in the EUDF. As you can see, ranging from people living with diabetes with our proud partner, International Diabetes Federation Europe, IDF Europe, JDRF, but also Primary Care Diabetes Europe, also the Federation of the Diabetes Nurses, and as said, also industry. And we, in Europe, put the focus on data and registries and how to harness everything we already have to really measure and improve outcomes. We also put emphasis on this novel technologies and digitalization and integrated care. And then we try and motivate different countries to also create these forums. And it will not surprise you that Belgium is one of the best pupils in the class, where the Belgian Diabetes Forum very rapidly was started now more than a year ago, and where again these pillars were also used. We also have similar forums, for instance, in Romania and in other countries. They're also looking at creating these forums. So join us in following us on Twitter and visit our website, udf.org. And again, I'm now very proud to introduce two active members of one of the strategic fora, namely the Forum on Data and Registries, where we discuss how we can really make policy recommendations, how we can give practical recommendations on the European level. And that is Dr. Katarina Eeg-Olofsson and Dr. Helen Colhoun. And they will share with us their best practices, their experience on data registries, and how they can really impact on quality of diabetes care in their countries. And the first speaker I have the honor to introduce is Dr. Katarina Eeg-Olofsson, who is senior consultant in the Diabetes Clinic Institute of Medicine in the University of Göteborg. And she is also director of the Swedish National Diabetes Register. So Katarina, the floor is yours.
Thank you very much. Unfortunately, I have an unstable internet connection, but I hope it's gonna work. Thank you. And I just want to say to Martia that you had some really important points that I hear from patients in Sweden too, and we discuss them continuously, and you'll see what you think about the Swedish experience. But it's been can you see when I point here, or is it no?
No,
I cannot. No. So I will have to talk you through it. It's the registry started in '96, and as you can see on the little chart to the right, you can see that it's been growing ever since. And it's not the number of patients with diabetes, it's the number of patients in the registry. So there's been a long time of sort of getting acceptance for the registry. And now with both the providers and the authorities wanting this, as well as the clinicians where it started, we have an almost 90% coverage of both type 1 and type 2. And since 2018, it's also including all both the children's registry and the adult registry is in the same. And the goal is in diabetes care is at least one annual visit, and that is reported. And last year, with a COVID pandemic, was the first time that we actually had a drop in visits, but it's still 420,000 visits. When you talked about do we know the prevalence or the incidence in diabetes? It's not an incidence registry, it's a quality registry, so we can't really tell, even though we have a high coverage, we're not really sure how many people get diabetes each year. But we can do calculations on that, and we know broadly the prevalence of diabetes. But it's the basic for the quality registry is that we have the information in the medical record to start with. And today, mostly in primary care, it's over 70% that are directly transferred after a clinical visit. And there's also an online registration from clinics, mostly those from hospital clinics by nurses and physicians after a visit. But to start with, the data we record are very clinically relevant variables in line with national guidelines. And to start in '96, there were not as many as there are today, but we've been very careful about increasing the number of variables. But for instance, the LDL cholesterol was added in 2003, physical activity in 2005, severe hypos in 2009, and just the most recent is the time in range variable. But this is, we want to have high coverage and very high acceptance for the variables rather than to have all interesting variables in the registry. And we have now, since 2017, pilot units using the diabetes questionnaire, adding PROM and PREM data, and then this picture sort of shows how we can access data. This is the group level, easy accessible data, which is on a group level, the units are not anonymous. We can go into this, if you see the center part here, knappen, the button, that it's you press the button and you get the statistical report that you want. And to the far left, you can see the lipid lowering medication, the proportion of patients on lipid lowering medication, type 1 diabetes, age over 45 years. And you can set this, you want the oldest or the youngest, and you can see that it's been increasing over time. And to the right with the blue bars, you could see that there is a difference on this lipid lowering, the lipid lowering medication in different parts of Sweden. And if I can access my own data, I can go click on the blue bar that is Västra Götaland, my part of Sweden, and I will get the green bars, which is every hospital. And I can see that my hospital is in the middle. I can see that certain hospitals have higher proportion of patients. And of course, I don't know if those are with high CVD risk, and there are many explanations for the differences. The point is to be interested in your data. And for instance, the thing with looking at the technologies with the access of sensor-based technologies, we could, a couple of years ago, we could do the same, and we could see there was a big difference. In some parts, there were 80% of patients with type 1 diabetes on sensors. There were 40% in other parts, and that sort of moved the whole spectrum, that patients in regions with less access to technology moved quicker. So it's been used also for everyday clinical life for patients. You can take the next one. And this is just to show the main indicators we have. There are more, but these are the main indicators that we have for benchmarking. So when you open up the registry homepage, you see your unit or your region, in this case, how we measure up compared to a national level. And this is changing every night. Some units they report every day. Some units report only once a year. So that differs, but it is the data set is sort of evolving day by day. But if you get a red dot here, you know that you're below national average, and that should make you go into your own data and see, what are we doing? Do we have a special, can we do something here, or is it, this is the way it is at our clinic? So these are the sort of the main 12 indicators that we have chosen that are in line with what the National Board of Health and Welfare in Sweden also have set a national target level on. So it's the HbA1c, of course, blood pressure, but of course it's also the process measures that you have, your foot examination, your eye examination, in things that you actually can improve. If they're not good enough, we can improve at a local unit level. And of course, from a patient perspective, it's just a lot of numbers, but it's also a lot of concern and worries about not getting your eye examination on time. So that will also sort of, you can point out that in this region, we don't get to do the eye examinations on time. What can we do about that? Next, please. And this is also an important part of the registry. And this is to really use the register, and we can combine it, link it to other registries, outcome registries, national registries in Sweden. But it's also important to discuss the results. These are patients from Sweden, up to date in real world data. How are patients with diabetes actually, what about their risk? How about risk factor control? Does it matter? We know from many other studies that of course it matters, but really addressing it in a local study with the data from the National Diabetes Registry in their own country, it's an extra, there is a pride from both healthcare professionals and patients contributing to this. And also just we've been doing comparisons to other countries, and that is also sort of inspiring. Where can we improve? How can we do it better? And the top picture there is, for instance, that when we have been looking at adherence to lipid-lowering medication. How many, when I prescribe a prescription for lipid-lowering medication, how many patients just really fill them? So we can go out and fill prescriptions and see that there actually is a difference in the rates of cardiovascular events, depending on how you fill your prescription. And this is also something for nurses and healthcare professionals, physicians to address. That does the patient take their medicine, and if they have side effects or whatnot. So just the final picture there is that we started out, the next one. So we started out with clinically relevant variables, easy to feed into the registry. It's not always been easy, but it's with more the getting it online has made it more easy, and the direct transferal from medical records. And the discussion, of course, if my unit has fewer patients reaching targets, that have many different explanations, but it's the knowing that my unit, the results from my unit will inspire me and other units. And the registry-based research is also important to sort of feedback the new information. So we know what we want to do from guidelines, from research, and we need to see that it's really put into action in diabetes care. So the benchmarking, I saw on your slide that you had the units were anonymous from the start. The units were anonymous in our registry as well. And a couple of years ago, it's all open. And that is actually, we think that is an advantage when the country and healthcare system is ready for that. It's not to be sort of say that you're doing really poorly. It's to say, how can you improve? Learn from good examples. And the patient involvement is getting stronger and stronger. Patient can access their medical data, and they can also access in the medical records, but they can also access in the registry. And I would say, knowing that my patient can access the medical record makes it a little bit, you know what you're writing, even though you know most people will not read it, but it gets a little thought that you write in a way that could be understood. And it's also the same in the registry, that you could go in, look at your results, and question your diabetes team on how to get the way that you want your healthcare to be in the best way. And the diabetes questionnaire, it's just started, but we think we have come a bit on the way. Thank you.
Excellent. Thank you, Dr. Ego Olofsson. And I understand you can join us for the debate at the end of the session. Yeah. Excellent, because there are several questions for you. And now we move to another country again. Now we go to Scotland with Professor Ellen Colquhoun, also a member of our Data and Registries Strategic Forum at EUDF. And Dr. Colquhoun is located in the University of Edinburgh. And so we in Belgium very enviously often look at also the Scottish registry. And so Ellen will introduce in a pre-recorded message the Scottish system. Philippe, you will launch the movie, I guess.
Hello, I'm Helen Colquhoun, and I hold the AXA Chair in Medical Informatics and Epidemiology at the University of Edinburgh. And today I'm going to talk to you about our National Diabetes Registry and the associated diabetes research platform that we have in Scotland. I'm just going to try to focus on some key features of it in this short 10-minute presentation. So in Scotland, we have an electronic healthcare record called Sky Diabetes. What this is essentially a federated e-health record system. In our secondary and tertiary care clinics, and indeed also in our chiropody clinics, community nursing clinics, there is access by a clinician to an e-health record called Sky Diabetes that is used for the general management of the person with diabetes, and in which data are collected and recorded in a standardized way. In addition, the database into which such data flow is also populated on a nightly basis by an upload from every primary care practice in the country of key fields from anybody who has a diagnostic record, a diagnostic code for diabetes in their primary care record. Entry into the register occurs either when in a new diagnosis of diabetes is made in the clinic, in which case a new record in Sky Diabetes is opened for the person, or it is also triggered by a new diabetes code being newly populated in a primary care record for a person who has recently been diagnosed with diabetes. These data are technically held at health board level. Our healthcare system is organised into 14 health boards, but in reality, the underlying database is really a federated database that one can run a query across all of the data from all of the boards simultaneously. And indeed, such queries are run on an annual basis, for example, to support our national diabetes audit. And we produce a report called Diabetes in Scotland from that, in which we report on things like attainment of HbA1c targets, blood pressure targets, food screening, retinopathy screening, and so forth. An important feature of the system that's recently been developed is a dashboard where the clinician can actually get summaries of their clinic's data with comparisons to national attainment, for example. They can see the proportion not meeting a target, let's say for HbA1c, and then they can drill down and list out which of their patients need to have further, more intensive management of their HbA1c. Now, data from this underpinning database is then transferable in an anonymized fashion to our local safe haven in which we develop it and make it available for research purposes. And this next slide tries to summarize that process. So we get data from the diabetes system itself, Sky Diabetes, and then through a linker ID system, we can also get records for that same set of persons from our hospital admissions database, from registry of deaths, from maternal records, all prescribed and in cash prescriptions, and so forth. And these latter data sets are held by Public Health Scotland, and they form administrative data sets in our national healthcare system. And so we have a mechanism whereby in our research platform, we can receive in these linked files where all personal identifiers have been stripped away. We then take these data and we put it through what we call our extract, transform, and load layer, which I won't go into too many details of, but suffice it to say, in this layer, we clean the data and we also array it in a way that makes it more user-friendly for research analysis. And this layer has taken, is a constant work in progress. Currently, it contains about 55,000 lines of Python and about 40,000 lines of code in R, to give you some idea and feel for the intensity of that work. And then the cleaned resultant data tables are made available into our national safe haven for research use. And if you're going to build such a layer underneath your diabetes registry, I would advise you that a very key point is that you must have in this space a means whereby there is constant interaction between clinical epidemiologists who understand the provenance of the data and software developers and programmers who can array it properly and analysts who are going to be actually crunching the data for data reports. Now, some broad reflections on the registry and the underlying research data platform in Scotland. I think challenges for the future and ongoing challenges are ensuring direct data flow from new devices. This is complex. It has complex privacy, governance, contractual issues involved in it in relation to device providers within your healthcare system. But a key point is that I think that if your healthcare system is reimbursing such devices, it should try to capitalize on that in terms of coming to an arrangement with device providers that the e-health record can be populated with such data subject to the individual patient consent. Another aspect which is of growing importance in the future is the ability of people with diabetes to submit their own data into the system. We do have such portals called My Diabetes My Way. A patient can register to say that they want to be part of this. Then they can view their own individual data, see how their results compare to the average of their peers, and they can also actually submit some of their own data, for example, from Dexcom devices or similar. More broadly, I would say it is very important to have stakeholder involvement. We do a lot of work with people with diabetes themselves, with diabetes charities, to show them the usefulness of the data and how it influences individual patient care and how it influences government investment in the care of diabetes. We also have very formal structures that reflect on the use of these data, view it on a very regular basis in the essentially the equivalent to Ministry of Health. It is regularly reviewed. The data that comes off the system is reviewed, in fact, on a monthly basis to track target attainment and to predict problem areas in the care. And we also, at every health board, we have something called a managed clinical network with representation from people with diabetes and many other clinician groups, in which the data are reflected on and decisions made about any changes in direction of care that are warranted. The system that we have is in principle generalizable to other chronic conditions where there is an agreed e-health record in place for managing care in primary care and where there is an agreed e-health record for secondary, tertiary and community settings. As a minimum, such e-health records require some degree of interoperability between geographic areas and between systems. And of course, it is the whole process is simplified by having fewer differing versions of e-health record systems. I think in terms of research data use, that system is also, of course, generalizable to other chronic conditions. And key to facilitating this is to have mappability to some common data model like CDISC or OMOP or so forth. And I would just then like to finally finish off by saying, of course, a very important consideration in all of this is data governance and privacy. And we have a very well worked through system now, which evolves through time, but is now reaching some degree of stability, both for applying to be allowed access, for example, to such data for research and where one can access such data. So we have safe people, safe processes, safe places are our pillars of our data governance strategy. For example, any user must have a certification in data governance, having done a data governance and security course. And in terms of safe places, for example, all data use takes place within safe havens, which must demonstrate both technical, managerial and process level security processes. So I will finish on that note. Thank you.
So we hope that you enjoyed these visions from abroad, and I hand over the baton now again to Dr. Nobles.